Frequent question comes about when we have a post and core that needs to be removed from a tooth. As you've seen on the radiograph, this particular tooth, which will be an abutment for a bridge from here all the way over to here, has an incomplete endodontic fill and a very, very short post. So it's not providing sufficient support as a pure abutment for the anterior bridge, and the insufficient fill leaves us with some misgivings as to its long-term prognosis. So the idea then is to remove the post and core in its entirety and retreat the tooth endodontically. The post and core isn't loose, and the temptation would be to just remove it by cutting straight across the base of it so that we have a traditional stump left. However, if we get a good look at the lingual surface, there is a fair amount of lingual tooth structure remaining. So what I will try to do is to just remove the gold and leave the lingual tooth structure in place. And to do that, I'm going to be using a 557 crosscut Fisher, because that most efficiently removes the gold. And I will start by just creating a slice right down the middle, and then work my way in from the sides and see what happens. Now, sometimes we get lucky, and the vibration of sectioning the piece will actually cause the cement seal to break and the entire post will float out of the tooth. Sometimes we don't get lucky and we have to remove it by drilling it out, and we'll see how this happens. Throughout the whole process, I'm being very, very careful to just cut through the gold, and when I see white structure underneath, which is either composite luting agent, zinc phosphate, or dentinal wall, I stop, because I'm trying to do this by just removing the gold and leaving the tooth intact. Now I'll take a peek at the palatal surface, and I'm going to come through here. Just to the edge of the remaining dentin. And as you can see, everything flew. That was just what we needed to liberate the entire occlusal portion of this. And we see one little tag of gold sitting right here. Okay, well now I'm going to dry it off and get a good look at it and decide which burr to use next. You may or may not be able to see a little gold dot right in the center of the tooth as the post is going into the root canal space, and it's right here. Here's a little piece of gold foil. It almost looks like foil that we can flick away, and right here we have the remaining stump. Okay, now the question is, how do we remove that? And the answer is with a very, very small burr on high speed. There it is. And very careful drilling. The first thing that I'm going to do is take one more look at the radiograph to see what direction the little post is going in, and it seems to be, at least from the mesial distal positioning, dead center. And it does follow the course of the root canal system, and that's good. And the next thing I'm going to do is try to determine the anterior-posterior pitch of the tooth simply by palpating, so that I can see what kind of a flare we have. And once I've determined that the angle or long axis of the tooth is like so, and that my mesial distal position is like so. I'm then going to very slowly, using a quarter round, begin to remove gold post by placing the head of the burr right in the middle of the post. And the limiting factor on how long you continue with this is the accumulation of water in the patient's mouth and your own fatigue. You don't go too long without stopping and taking a bit of a rest and checking to make sure that you're on course. Now, if you feel the burr suddenly touching something soft, back off immediately, because that means you're no longer on the head of the gold, but the burr is glanced sideways and it's into the internal walls of the root canal space and in the way of and engaging dentin. Our idea is to just remove the gold and nothing else. So I'm now going to take a little break. And with the mirror, notice that I'm sitting right on top of the gold. And having done that, I'm going to go back. Now, one other thing you may notice, this burr is actually long enough to get into the root canal space, but what if we had adjacent teeth? Then the base of the handpiece may bang into a cuss tip like so. And if that occurred, then I wouldn't have enough length on the burr to actually remove a long post. If that was the case, then it would be necessary to switch burrs. Here we have a standard size round burr, and here we have an endodontic round burr, a surgical endo burr. And it's long enough then to enter into a tooth where you have teeth on the adjacent side. We won't need it in this instance, but it's something to be aware of. Okay, now we haven't been drilling all that long, and already I'm going to stop because it's time to take a radiograph. We don't have any x-rays yet that actually show this as our endpoint for determining how far down this post is and how far down we have to go to thoroughly remove it. So we're going to take a radiograph to do two things: to show us exactly where this endpoint is so that we have a measurement, and also to confirm the fact that I'm on target and I'm not deviating off as far as drilling the precise center of the post. So, after the radiograph is done, we'll be back. Here we have the check radiograph, and it's a bit foreshortened, so it's a little impossible for me to actually get a pure reading on the length. From the XCP holder to the bottom of my drilling, I have about 3.5 millimeters, and when I use the perio probe here, it's more like 6. So I know that I can't trust this radiograph on length, but the remaining post itself is at least 4 millimeters on the radiograph, so I know I have at least that far to go, and then I'll do another check x-ray. The other thing that this shows me is that I am on target, but I have a little bit of residual gold along the wall on the mesial that I may be able to free up or pick off. So I'm on target. I could go a little bit more toward the mesial of the tooth to stay in the gold, and I have a little wall of gold that's still remaining. I've been within the body of the post. So now I'll continue. as before, my goal is to feel the resistance of the gold at the tip of the burr and to maintain the proper position both mediodistally and faciopalatal. At this point, it almost feels as though something's starting to loosen up a little bit. So I will once again get it nice and dry. And pick away at the gold that we saw radiographically was on the mesial aspect of this. And now bent that in. Remove this with the burr. Now the distal-lingual aspect of the gold seems to be bending in with the Explorer. And indeed, the whole periphery of the post is now starting to pull away from the inside of the canal. I know at the moment I'm blocking the view of the camera. But I need to be able to look into it directly. There's even a little bit of it on the facial wall, on the distal wall, and on the mesial wall. So, back we go. Go ahead. A little slide.
Thank you.
Good. And there we have the end of the post. Is it visible on my finger? We can now see it. And if you take a very, very good look at the post, you'll notice that all of the drilling was right within the center of the chamber of the post. Okay, now it's time to get a final radiograph to make sure that everything is out. Alrighty, now I'm looking at the final radiograph. And when I measure the entire space from the top of the preparation down to the top of the residual gutta percha, it's 8 millimeters. And I place this in, and it's 8 millimeters. And the radiograph confirms the fact that the entire post is removed. So now the next step will be to return to endo for removal of gutta percha and retreatment of the tooth. Thank you very much. Our second example of post and core removal involves the removal of a parapost from tooth number 11. Our first radiograph shows that the crown and underlying core buildup are totally absent. The second radiograph shows that we've made progress to the extent of 3.5 millimeters or so beyond the occlusal surface of the remainder of the tooth itself.
maintaining once again a pure straight course into the body of the parapost. Radiographs 3 and 4 show progressive continuation of post removal as we proceed in apical direction with the endodontical surgical round burr. We needed to use this burr so that it would have the length for the handpiece not to be blocked by the adjacent natural teeth. The fourth check radiograph shows that we have removed the post and core to the base of the post on the mesial aspect of the root canal space. We must be very careful not to drill any more in that area or risk enlarging the space or perforating the root. Check radiograph number 5 shows that the vibration of the burr has dislodged the final apical portion of the parapost. One can now go in with endodontic spreaders to dislodge it the rest of the way so that it will drop down occlusally and come out of the tooth. Finally, with the parapost removed, a Gates-Glidden drill has been used to increase the length of the post space to within 4.5 millimeters of the apex. We are now ready to fabricate a new custom cast post and core pattern for this tooth. Our final example of post and core removal involves the removal of a crown and a post from tooth number 6. The first radiograph shows a radiolucency at the base of the crown, which is associated with a fractured crown, the crown and post being fractured right at the level of the gingival margin of the crown. The first check radiograph shows that the most coronal portion of the post has been removed and that the round burr is true and on course within the body of the post. This radiograph also shows that the cast post and core is not precisely located in the original root canal system. It is, in fact, deviated toward the mesial, the post space having been prepared at the expense of the residual dentin on the medial wall. The second and third check radiographs show progressive removal of the post bulk in line with the original position of the root canal fill. The next radiograph shows a Gates-Glidden drill in position lateral to the remnants of the original post and core and apical to the termination of the post and core. The decision has been made to abandon the removal of the post material at this point in time because it is not in the way of a definitive repositioning of the new post space in the original root canal system. Our next radiograph, which is the fifth check radiographs, shows that gutta percha has been successfully removed for approximately 4 millimeters apical to the remnants of the original post, and that there is now a complete opening for the new post and core from the occlusal surface of the remaining tooth all the way to the new termination for the post and core. The next radiograph shows the seated post and core, which has been fabricated to completely obturate the root canal space, and you will notice that it does indeed follow the track of the original gutta percha and bypasses the remnant of the original post and core, which remains embedded in the lateral wall of the dentin. And finally, in our last radiograph, we have the completed project with the post and core in place and the new crown cemented permanently.